The right to life is a fundamental human right. Yet, institutional policies that facilitate tobacco use in mental health settings effectively compromise this right, particularly for those already vulnerable due to mental illness. When healthcare services enable a killing addiction through permissive smoking policies, they become passive participants in shortening patients' lives. This is not just an issue of clinical practice or institutional policy. It is a human rights concern. When mental health workers tacitly accept tobacco, this becomes a source of systemic failure to protect the most basic human right, the right to life itself. Any argument about personal choice must be weighed against our duty to prevent premature death, especially in those under our care. Recent research in the last 10 years has shown strong associations between mental disorder and smoking. Causal links are forming that there may be a biological foundation for vulnerability of people with mental disorders to risk of smoking. While research continues to explore the intricate relationship between smoking and mental health, the existing evidence strongly suggests a link, particularly for conditions like schizophrenia and depression. Waiting for definitive proof of unidirectional causality, an academic exercise, might mean missing opportunities to address the potential harm of smoking on mental well-being. The unfolding evidence is compelling enough to warrant action. Preemptive action. Even without absolute certainty about causation, the potential benefits of quitting smoking for mental health are significant. Encouraging individuals with mental health conditions to quit smoking is likely to lead to improved symptoms and overall quality of life. Harm reduction. Given the known detrimental effects of smoking on physical health, promoting smoking cessation among those with mental illness is a harm reduction strategy. They already face a higher risk of premature death, and smoking exacerbates this risk. Dual diagnosis focus. Emphasizing the link between smoking and mental health can help address the issue of dual diagnosis, where individuals struggle with both a mental health condition and a substance use disorder. Integrated treatment approaches are essential for effective recovery. While further research is always valuable, it is important to act on the available evidence. By promoting smoking cessation and supporting individuals with mental health conditions in their quit attempts, we can potentially improve their mental and physical well-being significantly. Individuals with serious mental disorders who engage in long-term tobacco use face a convergence of detrimental consequences, a triple whammy effect. Firstly, smoking runs the realistic probability of worsening existing mental health conditions and potentially increasing the risk of developing new ones. Secondly, smoking significantly elevates the risk of life-threatening physical health conditions such as cancer, cardiovascular diseases, and respiratory diseases. Lastly, the financial burden associated with smoking, particularly for those on limited incomes or state benefits, can lead to neglect of essential needs and further exacerbate their overall situation. The strongest evidence points to a causal link between smoking and schizophrenia, with EMSA studies showing a more than twofold increased risk. The persistence of permissive attitudes towards smoking amongst some mental health workers represents a remarkable form of institutional denial, if not apathy. Despite overwhelming evidence that smoking significantly worsens mental health outcomes, reduces medication efficacy, and dramatically shortens lives, many healthcare professionals continue to remain passive about this lethal behavior. This is not mere institutional inertia, it is a collective ethical failure. That such attitudes persist in the face of high-quality evidence suggests something more troubling. A deep-seated cultural complicity that prioritizes perceived short-term pragmatism over our fundamental duty to protect life. Psychiatrists who adopt a permissive stance towards smoking during Section 17 leave are failing in their fundamental duty of care. This failure is particularly egregious as it transforms a therapeutic intervention, leave from detention, into a mechanism for maintaining a lethal addiction. These clinicians are effectively using their statutory powers to facilitate a diagnosed mental disorder that kills half its long-term sufferers. The argument that we cannot prevent smoking during leave misses the point entirely. Our duty is not just to avoid enabling harm, but to actively prevent it. When we grant leave knowing it will be used partly for smoking, we become complicit in maintaining both the addiction and its lethal consequences. That some clinicians view this as acceptable practice, despite their GMC obligation to make patient health their first concern, represents a troubling departure from basic medical ethics. This is not about enforcement. It is about maintaining clear, consistent clinical standards that prioritize life over expediency. The sheer weight of evidence demonstrating smoking's lethal impact on people with mental illness seems powerless against entrenched institutionalized attitudes. This represents more than mere resistance to change. It is a collective moral failure that costs lives daily. That such attitudes persist, nebulously out of sight, despite irrefutable proof of harm, suggests something deeply troubling about our profession. We seem to have somehow normalized our complicity in maintaining a lethal behavior that we would never tolerate in any other context. This seems to be more than professional inertia. It is an ethical blindness that makes us collectively complicit in a devastating triad, maintaining a killing addiction, prolonging mental illness, and contributing to repeated episodes of psychiatric illness. Each element preventable, yet each enabled by our collective failure to act. The capacity argument creates a troubling paradox in healthcare. While we must respect that capacitous individuals can make unwise decisions, this legal principle is being used to justify institutional inaction against a killing addiction. The law, in attempting to protect individual autonomy, has in effect created a framework where healthcare professionals are compelled to allow harm. We find ourselves in the absurd position of being legally compelled to go softly on a diagnosed mental disorder, nicotine dependence, while treating other mental disorders, simply because patients may have capacity to choose to shorten their life and court dangerous medical conditions. This reveals a fundamental flaw in how capacity law interfaces with healthcare professionals' duty to prevent harm. The result is a system where we must watch patients with capacity literally pay money to the government to kill themselves, while our professional duty to protect life is rendered impotent by rigid legal interpretations of autonomy. However, in a free and democratic society that values human rights, the autonomy to irrationally consume killing substances must be respected. Perhaps the most bitter irony in this tragic situation is that the greatest beneficiary of healthcare's ethical paralysis is the government itself. While healthcare professionals wrestle with capacity arguments and passively enable a killing addiction, the Treasury profits handsomely, extracting around 70% in taxes from every packet of cigarettes bought by our mentally ill patients. This creates a perverse economic incentive where the state benefits financially from the very addiction that kills its most vulnerable citizens. Our patients are effectively paying premium rates through punitive taxation for the privilege of maintaining an addiction that will likely kill them faster. The government simultaneously funds smoking cessation services while reaping billions in tobacco taxation, a contradiction that would be laughable if it weren't so lethal. Mental health services have become unwitting accomplices in this macabre economic circle, where our most vulnerable patients fund the Treasury through their own destruction. We are therefore not just morally bankrupt, we are ethically disabled by a system we are forced to adhere to. In respect of Section 17 leave, our capacity to act according to fundamental medical ethics has been paralyzed by self-imposed constraints, permissive policies that enable harm, capacity laws that force us to facilitate destruction, and attitudes stand to contribute towards normalizing the maintenance of a killing addiction. This ethical disability is a product of our own apathy, constructed from layers of justification for inaction, upheld by misaligned respect for autonomy, and perpetuated by a state that profits from lethal cycles leading to an earlier death. We have disabled our own moral compass so thoroughly that we can no longer recognize the profound contradiction of healthcare professionals becoming agents in maintaining an addiction that kills those under our care. This is more than moral bankruptcy. It is a wholesale paralysis of ethical practice, where we have lost not just our moral assets, but our very ability to act on our fundamental duty to protect life.